Now I would like to introduce Michael Doonan. Dr. Deunan is an assistant professor at the Heller School for Social Policy and Management at Brandeis University and the executive director of the Massachusetts Health Policy Forum. Help me welcome Dr. Deunan.
Hello, everyone. It's great to be here. Let me just... And it's quite intimidating to be here as well. Dr. Hayes, you put together quite a group today. And I'm telling you, I'm intimidated for one reason, that's John McDonough. Because everything I talk about tonight, he had a hand in. And, you know, he was the executive director of Healthcare for All and was a major player in making healthcare reform in Massachusetts happen. He worked on Senator Kennedy's staff, helping make sure national reform happened. And in his work at Harvard, he follows it very, very closely. And then further down, Dr. Lindsay, Dr. Langer, you guys are going to be forced with what came out of the sausage machine here in Massachusetts and nationally. You're going to be tasked with making this work. And you all in the audience, you're not just going to be bystanders of this healthcare reform here in Massachusetts and nationally. It's going to affect you. It's going to affect the people that you work with every day. It's going to affect the care that you get, the care that the folks you get. And I think, I don't think we've got a perfect plan here in Massachusetts or nationally. I don't even think it's close. But I think that we are in so much better position. Imagine being someplace else in the country, a place like Texas, where 25% of folks are uninsured. You know, in Massachusetts, if you're uninsured, you can get some help. The rest of the nation, you can't. But there is help on the way. Is it a perfect plan? Is it convoluted? Did John need more time? Yeah, and there's nobody better in the country at explaining this than John McDonough. All right, let me use my time here to go over some sort of, back to the roots here, to the problems. What are the problems that healthcare reform is going to address? I'll do it quickly, but we shouldn't lose sight of what the problems are. And I think John talked about the range of things. So it's not just access, but it's also cost and quality, and maybe transforming the healthcare system to make it more efficient, to make it better. So we'll take a look at the problems, the options, and spend most of my time talking about what's happening here in Massachusetts. And then we'll make some connections to national reform, talk about some implementation challenges, and Massachusetts healthcare reform, the next step is cost containment, and some legislation passed. We'll talk about that. Yeah, it's the triad, the three stools, and if you've been in your graduate classes, you've talked about these. It's access, cost, and quality. The United States, we are the most expensive in the world. Nobody even comes close. Technology is the driver. Our current system is based on employer-provided insurance. I get my insurance through Brandeis University. Thank you. We have major government subsidies, Medicare, Medicaid, and also the insurance that we get through our employers. It's tax deductible. I mean, it's not part of our income. So there's major subsidies that we all get. And the cost, astronomical. Big numbers. Okay, but what is so disturbing is we pay the most. Do we get the most? Do we get the best quality care in the world? Well, no. No, we have higher infant mortality rates than some countries of far less means. We're not living longer. Of course, there are lots of things that determine what health is, and health insurance is just a part of that. But many have difficulty seeing physicians. We've got 47 million uninsured in the country, where we're spending the most per capita. We're not getting the highest quality. We're not covering everybody. And this is a big problem politically. And I think national reform couldn't have happened without Massachusetts reform, and we can go into the details of that. But it created a new model, this notion of shared responsibility. We asked more of government, more of individuals, and more of employers. And Massachusetts kept the stakeholders connected. In the past, the medical association or the pharmaceutical company or the hospitals or some group wanted this kind of reform, and they wanted this, and nobody could come up with any consensus. Massachusetts broke the mold, made it happen on this notion of shared responsibility, keeping stakeholders connected. I'm a political scientist. I'm interested in power. I'm interested in interest groups and how things happen. And this is the way it happened in Massachusetts. Well, one of the reasons it happened too is they put off the toughie. They put off controlling costs until further down the road, and we'll end our discussion with cost containment. So how does it work? Well, one of the things individual responsibility. So I said individuals have more in this, and John talked about this as an individual mandate. We're required to have health insurance if it's affordable. Really, really important. And some studies said, you know what, you can't get to universal coverage, you can't even get close unless you have an individual mandate. But it's just crazy to have an individual mandate if it's not affordable, right? Is it fair to say, all right, you have to have this thing and it's getting more expensive every year? That makes absolutely no sense. So that puts pressure on the political system to make sure that subsidies are available to at least make it reasonable. So there's government responsibility, and there was expansions of Mass Health, which is the Medicaid program in Massachusetts. And there was a new program called Commonwealth Care. They had a whole bunch of insurance regulations that helped make health insurance more affordable, especially in the individual market. Gosh, if you're looking for individual health insurance, you are in the worst shape possible, or you used to be before reform. So, or especially, you're 55, you're not eligible for Medicare yet, and you're looking to buy something that's really, really expensive. Well, what is the insurance company going to say? Well, why are you looking to buy this thing that's really, really expensive? Well, because you might need it. So what are we going to do with the insurance premiums? Jack them through the roof. So Massachusetts has some insurance reforms that puts everyone together. Takes the individual market, those individuals looking for insurance, and the small group market, and combines them together. They can go to the healthcare connector, and especially in the individual market, they can get a much more affordable product, even if they don't qualify for subsidies. And then we've got this healthcare connector, the Travelocity.com, as John referred to it, that has two separate sections. And also they created a quality and cost council. So let's spend a couple minutes on Commonwealth Care. It provides subsidies, right? The individual mandate have to have some subsidies. Sliding scale up to 300% of the poverty level, which is just about over $30,000 for an individual. For people at or below 150%, there's no premiums, no monthly premiums. So is that affordable for these folks? Does the individual mandate make sense? Yeah, it does, because it's affordable. And then there's a sliding scale from 150 up to 300% of the poverty level. But then at 300% of the poverty level, say that's $35,000 for an individual, and you have to buy the premium yourself, and the premium is $7,000, $8,000. Does that sound reasonable? No, that's a huge percentage of your income, right? It is. But say you're employed, and your employer's paying 70%, and you're paying 30% of it. That might be more affordable, right? So so there's a bit of a cliff there at 300%. But the legislation, the statute, the law says if it's not affordable, then you're exempt from the mandate. So if it's so there is residual folks in Massachusetts that don't have health insurance. Okay. So people went into different buckets here. More people got coverage through this subsidized program. More people got coverage through Medicaid. More people signed up at work, and more people signed up in the individual market. And in terms of access, it's working. 98% coverage. But did it get costs under control? No, but it didn't exacerbate costs. It didn't increase the problem. It still is a problem. And we'll hear a bit later that there is a shortage of primary care providers in the state. And this picture here just shows some irony. George Bush it said, Massachusetts, you can't go on unless you change your healthcare system. So that drove healthcare reform in Massachusetts. And Mitt Romney signed it into law. That created the Massachusetts reform, which Obama took as the backbone for national reform. And now, guess what? Massachusetts has to change a lot of its stuff, and it's going to be really complicated with what Massachusetts has to do. National reform and Massachusetts reform on access, on some of the points, very, very similar. But as John suggested, national reform does a whole lot more. The similarities are shared responsibility. They both have Medicaid expansions. They both have health exchanges. They both reinforce the employer provided. But in a sense, it was easier for Massachusetts because it had a lot going on than other states. So relatively low on insurance, a history of reform. It's not like some states like Texas with 25% uninsured. So nationally, politics is ugly. It's partisan. The House of Representatives just added a provision, a part of their budget to get rid of reform once again. Medicaid is huge. If you take one thing away from John's talk, Medicaid is going to put a safety net, finally a core safety net, across the whole country for folks below 138% of the poverty level, and it's really critical. These exchanges, they're going to be very complicated to roll out in each state. So what's now? What's happening right now? Well, the rules are being made for national reform as we implement reform here in Massachusetts, and implementation is going to be very, very, very difficult. So Massachusetts got to make some changes to its reform. It's got to sync up with this federal reform in terms of affordability and mandate penalties and subsidies. It's going to be quite complicated. They're going to have to get rid of the Commonwealth Care program and change that in some fundamental ways. Most of them that will be helpful. But cost containment is going to be tough, a tough pill to swallow. And Massachusetts passed cost containment legislation recently. And the state will certify ACOs. We might be hearing about more of them, patient-centered medical homes. It's going to aggressively try to get the state Medicaid program and state employees into alternative payments, to move from fee-for-service to more capitated global rate, to try to, and we'll talk more about this in questions and you'll hear more from other speakers, but to get more efficiency, to get away from the current system and to encourage prevention, to encourage wellness, and to get more efficiencies out of the system. It created a health policy commission headed up by Stuart Altman from Brandeis University that's going to set targets on increasing healthcare costs. There's going to be more transparency about price variation and control and reporting requirements. Okay, and there's additional wellness provisions in this legislation as well. Malpractice reform. Okay, so we've got the policy process, the legislative rulemaking, implementation, and then problem assessment and reassessment. Where do you all fit in here? Can you influence legislation? Can you influence this rulemaking? Yeah, you can. I think being here tonight shows that. It shows that you're engaged and active and understanding. Now you understand national reform more than 98% of Americans. So use that action when you're out there working with patients. If things aren't working, talk to your legislators. Get engaged because you are part of the process and we will all be much better off, won't we, Tony?
Yep. Yes.
Thank you.